Hello everyone. In this session, we'll try to talk about health financing. Health financing is an important area these days. Whenever we discuss about improving health system, improving health status or health seeking behavior, and what we have found that the one of the root causes that the health status of people in general in any underdeveloped country has not been good or has not been quite appropriate, just particularly because of the poor health financing system, and because it's not only accessibility of the healthcare for them but also the affordability to access them or to avail those health system. Even if the government provides in those countries or in these countries, the government provides the public health system or the health system is under government by a large margin, but at the same time the access of government based health institutions are not really up to the mark. Therefore, they have to rely on the private health system, and where they have to pay a user fee or they have to pay the treatment cost, they have to bear it by themselves, and often it has been a challenge for them, the poor people, underprivileged people, remote areas, that they end up having taking loans or losing all their savings in to meet the treatment care or treatment cost. Therefore, while this World Health Organization has given us six building blocks, they have identified to improve the healthcare or the health system healthcare system and status and health status of general people. Health financing has taken a very important place over there. I'll just broadly tell you which are those six building blocks. Number one, good health services. It talk about quality of human as well as non-human capital. Quality health service with minimum wastage of resources. Yes, this is the one, this must be the first one, that I give them the best quality health service without losing much of my wastage or losing much of my resources. So that should be the prime objective. Again, this is the first building block, based on that they have tried to feature. And then when they talk about this human and non-human capital, the first thing is that human capital. So in point 2, we will discuss about health workforce. So there should be sufficient number of qualified staffs, a fair distribution of staffs, that both the urban and rural area should have enough number of healthcare staffs. They should be responsive and productive. Number 3, after we ensure the health system, health workforce performing well to achieve a quality health care, which at the first building block they have talked about human capital as well as non-human capital, reducing the wastage of resources. The third thing comes as health information system. Everything is now data driven. Health information system, even now the the primary health centers in India, if they have to send a report or send a weekly report or monthly report, they just scan their hard copies where they keep the information and send them. They don't really take them to a the individual information or the micro level information. They don't take them in an Excel file or something like that. The whatever I have seen, that the Excel file contains, in the best scenario, the Excel file contains the monthly consolidated number, that what is the patient footfall, if there is a major disease, how many people who have suffered from the disease, what is the total number of immunization, but not how many or of which age, which gender, nothing is given there. The individual information has not been mentioned there. Still something is there, and that's the best form what we can have now. So the health information system should be consolidated so that both the private, public, primary care, secondary care, tertiary care can all be consolidated, and and we can ensure the universal health coverage. Number 4, it should be the medical products. Safety, efficacy, and cost effectiveness. Along with technological advancements. So this is non-human capital. This is my non-human capital. The fifth one is health financing. The fifth one is health financing. So health financing should raise adequate fund which can ensure the the affordability of the people. So the government, and whatever we have seen in our previous discussions, the government expenditure or the proportion of government expenditure or proportion of the total GDP, the country's income, going towards health expenditure is a very, very important indicator of development of a particular country or state. Therefore, health financing has taken a very important place over here in the 6 building blocks, and which is the fifth one. And then it says to ensure the universal health coverage, which is the primary goal of this World Health Organization or World Bank or UNDP, United Nations Development Programs. So the universal health coverage, that is health for all, health being the basic or fundamental rights. So and you have everything around you, but you don't have money, so you cannot really access them. So the affordability as well as accessibility, accessibility cannot alone ensure the best of the health. So affordability should be there, and therefore the health financing, and it's government responsibility that how they set up a structure, whether they ensure that health insurance should be the primary factor behind the payment mechanism, whether they think that I should pay out of the taxes, or I will subsidize the private institutions wherever I cannot reach as a part from the government's responsibilities, or it should be some managed care organizations should be brought in. So this is government's prerogative, and the final idea should be that how far the out-of-pocket expenditure can be reduced. The lesser the out-of-pocket expenditure, the lesser chance of a family of a poor to remain poor, or going more towards poor, or a person or a family or a household who is around the poverty line or just above the poverty line, they don't enter the poverty line. Having said that, the last one is leadership and governance, because finally health, education, all these things are should be decision on all these things should be taken by the government. These are the this is kind of a primary sectors where the government's intervention is very very important, and the government should take the basic decisions, primary decisions in terms of regulations, in terms of laws, in terms of evaluations, bringing in different schemes wherever the market, the private market fails to bring the efficiency or ensure the efficiency. So it's government role basically, because the private organizations will have their profit making ideology, will have their own ideology. Not everybody will have a social responsibility, and that is why the government is trying to bring them under corporate social responsibility, CSR and all, so that wherever the government thinks that they cannot reach, so private can be brought in. So, and wherever the private thinks that they can avail some extra benefits from the government, so they try to work together, kind of in a win-win scenario. So it's like the corporate social responsibility is not basically a PPP, but it's a kind of initiatives taken by the private organizations to increase their reputation, to be in the good book with the government, that we have a social these things, so and these all decisions are taken by the government. So the leadership and the governance is very very important to ensure that how this entire health financing, the health budgeting will work out, and eventually if you see that that when we have these the budgets, the national budgets, one important, very important component is this health budget. So because health is responsible to develop a human capital for a particular country, and how the country is investing, as a policy maker, as a nation builder, how they are investing, that matters a lot. So therefore all these 6 building blocks, their prime idea is universal health coverage. Universal health coverage. So this says that each and every individual should be insured with promotive, preventive, curative, rehabilitative, and palliative healthcare. Promotive is awareness generation, these campaigns and all. Preventive is when immunization programs, giving IFA tablets to the pregnant women or women, that iron folic acid tablets, so that they don't fall anemic. So these are the preventive measures. Yeah, or regular checkup, eye camps, health camps. Curative is when a person falls ill, then the treatment process, that is curative. Rehabilitative is after the treatment process is almost over, the rehabilitation is taking place there, the rejuvenation, it can contain the trauma management, it can contain the simple physiotherapy, the mobility improvement programs. And then the palliative healthcare. Palliative by definition, it's not actually reduce the, or improve the health status, but it reduces the pain. Especially the palliative health cares are associated with the critical cases, when there can be extreme cases, when life threatening cases cannot be improved in terms of their health status, but the pain can be reduced. So, and it is individual level as well as the family level. And to ensure this for everybody, it's, and at a where both the accessibility and affordability, or with the highest best of the qualities possible should be extended or can be extended. The government has to think over what should be the health financing schemes, so, or how they are going to finance these particular causes or these particular treatment processes. There are three related objectives primarily under this universal health coverage. The three related objectives are: one, equity in access of healthcare; number two, quality of health services; number three, financial risk protection. Financial risk protection. So it's of course talk about the health financing, where the one is accessibility, another one is quality. The first one is accessibility, the second one is quality, and the third one is affordability. These three are the basic objectives under universal health coverage, and it has been brought by the World Health Organization in the year of 1948. Then came the Alma-Ata Declaration in 1978, and then all these countries slowly emerged to have a basic goal based program that is known as Millennium Development Goal, which had a set of targets till 2015, Millennium Development Goal. And then it moved to Sustainable Development Goal. After failing or achieving this Millennium Development Goal, the development programs are moving more towards this sustainability. So it's more of a sustainable development goal now, where people are talking about the inclusiveness mostly, that the health, the education, the poverty, the income generation should be, and all stratum of the population should be included in them, such as there should not be any gender differential, there should not be any age differential, inclusiveness in terms of these elderly, inclusiveness in terms of geographical boundaries, in terms of reducing the rich poor gap and all this. So why health financing? It's certainly because we have to ensure affordability as well as accessibility. And if, like, say, affordability, if we talk about a particular individual, then it is at the micro level. But if we are talking about the government, or about the state, the country as a whole, then it's a macro level. And not only that, that affordability will ensure that how best will be the services provided by my public sector hospitals, right? So I can maybe through my insurances and all, now I have affordability to pay, but the public sector hospitals are really poor. So it's not only from the patient's perspective or the potential patient's perspective, but it's also from the government's perspective. Yeah. The secondly is that with this affordability, the first thing is that not only the first thing reduces is impoverishment, not only affordability, because this affordability with the the low payment or low treatment cost, what happens is that impoverishment comes down, the poverty level comes down, or they don't fall into the vicious circle of poverty. A person who pays the one of the largest causes of poverty in India or any developing country has been identified as the health causes, funding the health causes. So, and that is why even the schemes like ESIS or RSBY, they are even they are targeting those people who are within formal sector, say the garages, the restaurants, the street vendors, all these, the cart pullers. At the same time, they not only give them a coverage, but also they cover their transportation cost or loss of income, because they are availing a health services. So that this associated costs is also taken care. It's not about just the cost they are paying for against the treatment, or even if it's the coming to a city from a rural area, even if the treatment is cost is very low, just the medicine cost, and that too very minimal. But coming for 2 or 3 people from city to the from urban area to the city, for rural area to the urban area, by transportation, losing a day's income or 2 days or 3 days income is a massive cost for them. The opportunity cost is really, really high, you know. And if it contains for a longer time, and if one person, you know, unfortunately cannot go for work anymore, and they have to, you know, be brought to the city or to a bigger health institution, then they are losing a lot of money, and then that can cause one, you know, bread earner is already gone, and then, you know, he is incapable or she is incapable to work anymore, and then with this additional cost, the impoverishment is guaranteed in most of the cases in a typical rural phenomena in any underdeveloped country. So the first thing is that impoverishment, yeah. So with the affordability, the second is that it also increases the accessibility, because if the government is covering for their health, for their transportation, for their loss of income, then they are ready to access the health institute or health a hospital which is maybe 80 kilometers away, and then otherwise they won't come. I came across the case that in a particular village which was very remote, and there was a, you know, middle aged or close to elderly person who was paralyzed after a stroke. And after he was paralyzed, once he was taken to the nearby district hospital, which was you know, not less than 70-80 kilometers from their home. And when he was taken for a few days for the treatment and nothing really improved, and then, you know, he had to he had to taken back to his own village, and then nobody bothered to, you know, continue with the treatment. No health camp was there, no treatment facility was there, or the treatment facilities didn't have enough they were not enough equipped with to, so that they can treat that particular case. So that elderly person was, you know, was really out of the healthcare. And then coming to that this plight, then an organization, they decided that they will this is basically under the university where I teach. So they basically decided that they will bring up, you know, a health camp in that village. But when the health camp was organized, just before that, just, you know, just few days before that, that person passed away, and almost without any treatment, because there was no transportation. Their family didn't have money to take him or to hospitalize him for a longer period of time, or to, they could not afford to, you know, dedicate a person, a family member who will be completely there taking care of him. So thus accessibility also increases if the individual is covered against these health costs, as well as the government has enough money, or the government itself is contributing enough money towards the health budget, so that, you know, regular health camps can be organized, or number of primary health centers can be increased, or more of the staffs can be increased in a particular primary health center, or the ambulances can be devoted in different villages, so that it improves the accessibility. And third is increased priority given to health, because once the government, or, you know, they are sensitized that you take the person to the healthcare system, you know, treat him well, or the government tries to sensitize, pushes, or, you know, injects a lot of money into that, then the people in general, they start thinking that okay, it's definitely important that, you know, the person really gets the proper care. So the health seeking behavior slowly changes and improves. Therefore, the financing for universal health coverage has two main components. One is to remove financial barriers, to access health systems, and number two, to ensure that they do not suffer from financial burden or financial hardship. Now, these two, even if they sound similar, they are different. Why they are different? Because in one point we are thinking about under universal health coverage that remove financial barriers. That means even if a person can afford, if they won't go to a doctor or a hospital or a proper treatment facility paying by themselves. Yes, they don't find that it is important, the increased priority. The priority is not never realized. So if you can, that they think that, oh, it's unnecessary, number one. Number two, they also think that it is unnecessary to pay for these health insurances, right? So the financial barriers, that the protection, the risk pooling ideologies are never there still in the rural areas, or the people for whom having an insurance is a luxury. Yes, so what happens is that if the government pays for them, if there is a scheme or if there is a community health insurance scheme where the contribution is very low, then that financial barrier to access, now we are bringing this affordability and accessibility to access, it comes down. The next one is that financial hardship, which directly talks about the poverty, that because of these payments, treatment costs, they should not be impoverished. Yes, one is that health seeking behavior, another one is even if they are going, they should not be impoverished. So these are the two ideas, one is the cost and one is the effect. So health financing levers to universal health coverage in three ways. So one, raising funds for health. Two, reducing financial barriers. And hardship. And three, ensuring equity and equality. Ensuring efficiency and equity by proper allocation and utilization of funds. Yes, of funds. So these are the basic three parameters which under universal health coverage, health financing tries to work on. So in terms of these the health financing institutions, they are there in the both micro level and macro level. As I said, in the micro level, it's individuals out of pocket expenditure, OP. Number two is can be their private insurance, or I will just say health insurances. It can be both private and community health insurance or public health insurance, any type of health insurances, government schemes, etc. These all are individual level, right? At the macro level, it is the states, international funding agencies like say World Bank, World Health Organization, UNICEF, yes. So these are the two macro and micro level funding organizations. Now, which are the basic primary health system financing sources? So the financing sources like say when we talk about both the micro and macro level, the financing sources, the first one can be private expenditure, like it can be, financing sources can be divided into two groups. One is private expenditure and the public expenditure, right. So one comes from, I should not write one comes from the private sources. It can be at the individual level. If I am paying for my health, that is a private expenditure. If somebody else paying, not the government, for my health, it's a private expenditure. If I am paying through some health insurance schemes, private health insurance scheme is a private expenditure. If the government is paying for me through earmark tax, if the government is paying for me under some schemes or some health insurance schemes, then it's a public expenditure. So the most important one is the public expenditure, what government pays through earmarked taxes or compulsory health insurance contributions. Yes. Number 3 is voluntary payments. By individuals or their employers. It can be private health insurance, it can be the employer provided health insurance, it can be direct out of pocket expenditure, anything, but broadly these are voluntary payment. Yeah, what government does, it's a primary, because they have already given the fund, so you are not paying anything, the government has already paid, so it's a compulsory. Or if you are under some schemes and which targets that 100% coverage, say central government health scheme, where whenever you are a central government employee, in whichever level, you are covered under the health insurance scheme. Or if the government is targeting with some, say Rashtriya Swasthya Bima Yojana, RSBY, which is a state, or ESIS, employee security insurance scheme. So all these are basically compulsory health schemes. So you, like, if I fall under that particular category, I qualify for those to be registered under those schemes, so I have to. The fourth one is that external sources. These are basically external aids, or the supports from international organizations, or it can be even non-governmental organizations, national level as well. So it can be international and national non-governmental organizations. Yeah, and then the last one can be, out of pocket expenditure. If I keep it separately from here, now this can be through cash as well as or kind, in a marginal, say for a marginal farmer who doesn't have any savings, so if they have to go to seek treatment from a private health providers, whoever it is, if not government, they have to pay something. So often they pay in kind, they don't pay in cash. So because they don't have cash, that's simple, they're so poor. So these are the basic financial sources, and these voluntary payments are mostly talking about these insurances. So this is all in terms of the sources. Thank you.